by the Ash Center for Democratic Governance and Innovation and the Center for Public Leadership. I am Parissa, Associate Director of Democratic Governance Programs at the Ash Center. And if this is your first time joining our events, the Ash Center is one of 12 research think tanks at the Harvard Kennedy School. And among the many things we do, we focus on bridging academia and practice to improve our democracy. Before we begin, the Ash Center would like to acknowledge the land of which Harvard sits on as the traditional territory of the Massachusetts people, and a place which has long served as a site of meeting and exchange among nations. And before I turn it over to our moderator today, just a few more housekeeping announcements. We will dedicate the last about 15 to 20 minutes of our time together for discussion and questions. But if you have any questions throughout the presentation, you should feel free to use the Q&A box to send them along, and we'll start collecting them. We also want to take the opportunity to invite the Harvard community and those that are non-Harvard community to share the great initiative that we have launched at Harvard called the Harvard Votes Challenge, a nonpartisan initiative striving to build a civic culture here at Harvard by increasing voter registration and participation across the entire community of students, staff, and faculty, and those that are joining us from Buyon. We invite all the participants of this talk to join the movement by registering to vote. You can find your school's voting team and more at voteschallenge.harvard.edu. We'll also put the link in the chat for you to click on. And again, this is open to non-Harvard people. You can update your voter registration through this link. And finally, this event is being recorded and could be found on the Ash Center website and the Harvard Votes Challenge website for future viewing. With that, it gives me great pleasure to introduce our moderator. Lucas Buyon is fourth-year doctoral candidate in the Department of Immunology and Infectious Diseases at the School of Public Health here at Harvard. And outside of the lab, he volunteers with the Harvard Votes Challenge to encourage voter registration and turnout amongst Harvard students. Welcome, Lucas. You can take it away.
Good afternoon, everyone, and thank you for joining us today. I'm pleased to introduce Dr. Deborah Turner from the League of Women Voters, Professor Parissa Ballard from Wake Forest University School of Medicine, Dr. Liz McKenna from Johns Hopkins University, and Dr. Alister Martin, a practicing physician at Massachusetts General Hospital and founder of Vote ER. Thank you for joining us all today. I think to start off, I want to begin by asking each of you the question, how do you link sort of civic participation with health equity and voter participation with health equity? Let's start off with you, Dr. Martin.
That's a great question, Lucas. For me, my start at this intersection between civic participation and health starts with stories. You know, as an ER doctor, every night, unfortunately, I get to see the faces of failed policy, of failed healthcare policy. I get to see the widening divide between policy creation in this country and rational thought and science. And one of those stories that moved me early on was a story of a woman who I took care of, who was in the ER on Christmas Eve in her mid-20s with abdominal pain. I remember doing the exam and feeling like I was missing something. We sent her labs off looking for either appendicitis or cholecystitis, or was this a UTI? And it wasn't any of those three things. She had something called starvation ketosis. Went back and I spoke with her and I said, look, you know, it looks like your labs are concerning for, you know, process that only happens when you haven't eaten in a long time. What else is going on? And she told me a story about how she lost her second income and lost her ability to pay for her meals. And she had to make a decision. Do I help my family pay for their medication, or do I pay for my own meals? She was in the ER because she was starving, because she had food insecurity. And that's the cause of her abdominal pain. I can't solve her problem with a procedure or a surgery or a medication. She can solve her problem by voting. We can solve her problem by voting, by creating a fair healthcare system that is able to take care of the most vulnerable. And we do that by first getting people registered to vote. As the late John Lewis said, the vote is the most powerful nonviolent change agent that we have in a democratic society, and we've got to help people make it easier to vote and to lean into their civic duty.
Thank you for that. Dr. Turner, if I could also have your response on this question. Dr. Turner, I think you're still on mute.
There we go. Sorry about that. Me and the buttons. Anyway, being a part of League of Women Voters and also being a physician for over 30 years now, I have really seen very much, like Dr. Martin has said, how these two things intersect. And, you know, I agree 100%, first of all, that there's no question that your vote is your main power in a democracy like ours. And nothing changes if we don't vote. But you have to have reason to vote, you have to have access to vote, and you have to have the capability. And we who have the power to make sure or to assure that each and every one can vote should be basically using it to help. Dr. Martin's story brought a story to mind when I'm dealing with in the medical world too. I had a patient who came to me probably about 5-6 years ago. I practiced gynecologic cancer for 30 plus years. And the patient came to see me, and she came via ambulance. And I was speaking with her, and she was in distress. And I asked her, you know, what her history was in that. And she says, well, you know, I have been ill for a couple of years now. And I said, oh, I'm so sorry, you know, why weren't you able to come? And she says, well, and she was in that demographic that I think a lot of us didn't understand, that one of the demographics in this country that has low access to medical care are women in their ages, like in the 50s or, you know, a little bit older than working age, who may have been married or had a partner who then retired and went on Medicare, and all of a sudden they have no health access. And that is a very common problem. So she had not come to see anyone because she had no access to healthcare. And she was now stage 4 cancer, subsequently passed on because of her cancer. But it really began to hit me that these are the patients, these are the people, these are our American citizens or our citizens in this country, or whoever lives in our country who need healthcare, and we are failing them. And the only way to actually support them and make healthcare more equitable is for people to vote, because the people making decisions about healthcare in this country are too often our elected officials. And if we're basically electing officials who don't understand and don't feel this pain, then we're not going to get things to change. So not only do we need everybody to vote, and we need to give people the opportunity to vote, particularly patients, but you also need them to understand that that vote is going to change so that they can be taken care of, and we can be taken care of. We can be a healthier nation. So,
thank you, Dr. Turner. Professor Ballard, can I get your thoughts on this question?
Yeah, it's a great question. I think that civic participation, and especially voting and equity, are related in so many ways. So just to name a couple, we know that we have health disparities in our country. We also know that we have civic opportunity disparities in our country, and those two things are not unrelated. So the people who are most impacted by health disparities tend to also be people who have fewer opportunities for high quality civic participation. Talking from my own research and from what we know from the research out there, civic opportunities in schools and other spaces tend to be really unequal, and that's an equity issue. So I think if you think at the individual level, we have some evidence that being civically engaged and voting is good for individual level health. It can be really empowering. But then more at the societal level, people voting and coming together to make their collective voices heard can impact policy that then can have positive returns for health. So they're really, really connected in a lot of important ways.
Thank you. And last up, Dr. McKenna.
Thanks, Lucas. So I am not a physician or a healthcare professional. I am a sociologist, and I am a postdoc currently at something called the P3 Lab at Johns Hopkins University. And I think what all of the panelists have said so far is demonstrates just how interlinked healthcare is with so many other issues. So health, education, climate change, et cetera. And what we study in the lab is the reason it's called the P3 lab is because there are 3 Ps for civic participation. It has to be possible. People have to be able to vote. It has to be probable. People have to be motivated to vote. And third, and most importantly, civic participation has to be powerful. It has to make a difference in the actual lived experiences, like Dr. Martin's patients, for example. So what we study here and what we're most interested in is how to make civic participation, all 3 of those Ps, irrespective of the issue area. And one of the tendencies that a lot of activists have is to slice and dice issues and look only at health or climate or education. But we at the lab are looking at ways in which the participation affects all 3 of those things, and therefore the health of individuals and communities at large.
Thank you. I think, in relation to this topic, obviously this is a pervasive issue. Health equity, healthcare access, and civic engagement is an issue that is still continuing on to affect all of us in non-pandemic times. We are, however, in the midst of a pandemic, and this is obviously incredibly complicating all these factors. And I'd be curious to hear from each of you about how you think the ongoing coronavirus pandemic is affecting health equity and civic engagement, particularly in regards to voting, which is a major topic in the news today. And I'll let it kick off to whoever wants to start off first.
Well, I'll throw my hat in the ring here. Okay. This is a really, really critical issue, particularly for the League of Women Voters. We have been spending a lot of time talking about issues around voting and how the pandemic is impacting them. And what we really see is when we look at voting and promoting voting in the United States, we think of first, obviously, protecting citizens or protecting voters and educating voters and registering voters, and then making sure we can get out the vote. And what we've noted in the pandemic, and which I'm sure the rest of the panel will agree, is that the struggles become how citizens are going to be able to vote in a time when they are afraid to go to the polls, and when justifiably afraid, and when we have many, many, many groups working to suppress the vote. And the pandemic has been the perfect tool for suppressing the vote, because what's happening is we're seeing voting sites decrease. There are fewer places to go vote. We are seeing fights against allowing voter registration and early vote or mail-in voting to move forward. And we're seeing multiple other attacks like that. So we're spending a lot of our time fighting that type of legislation and those type of issues. Simple things like, even a lot of people didn't recognize, to get a mail-in ballot, sometimes in some states you have to have an excuse or you have to have 2 signatures. Outrageous in America in 2020. And so we're currently engaged in over 50 suits across the country to alleviate these problems, which are being exacerbated by the coronavirus.
Thank you. Actually, Dr. Martin, if I may call on you, sort of shifting to sort of the emergency room perspective and vote ER.
Look, COVID-19 has made voting in the 2020 election a public health issue, full stop, for at least 3 reasons. The first is, you look across the country and voter registration rates are down at historic lows, in some places up to 70% down. And a lot of that is driven by the fact that DMVs were closed for several months in the last significant period of time. A lot of in-person voter registration efforts have been curtailed, rightfully so. The second issue is, you think about who is actually out there doing sort of the election officialing. It turns out that the average age of these election officials, these poll workers, are in their 60s. These are not the individuals that you want to get COVID when you look at the mortality data of who really gets sick from COVID. And then the last piece is that, for many of my patients who I see on a nightly basis in the ER, it's just not safe to go out and wait in a 4 or 5 or 6 hour long line with other people touching communal surfaces. I remember a patient I had a couple of weeks ago who was post-heart transplant on very aggressive immunosuppressants that, make the heart transplant work, but also predispose them to catching infections in an easier way. And so I had to tell this person, look, I don't think it's safe for you to vote in person. Do you have a mail-in ballot? Person said no. I said, okay, great. All you have to do is fill this out right now and get your mail-in ballot so we can keep you home. You can vote from home this year. And it's not just me. I'm part of 15,000 healthcare providers across the country who have these Vote ER Healthy Democracy kits who are saying that same thing to patients. And it's not just my hospital. I'm part of 100 hospitals and health centers across the country who are all part of Civic Health Month, who are stepping up in Civic Health Month to make this idea of safe and healthy voting in this 2020 election because of COVID a priority. So that's a little bit of the background on that.
I actually want to ask a follow-up question to you, Dr. Martin. So you created this organization called Vote ER, and I'm wondering if A, you can elaborate on it a bit more, and also B, since you've developed this organization and have deployed it at Mass General throughout the country, what have you learned since about voting registration in a healthcare environment, particularly in the midst of the pandemic?
That's a great question. So, my background is I came from the world of policy before doing emergency medicine training. I went to the Kennedy School and worked in state politics for some time. And so I've always been aware of the importance of electoral participation and the importance of voting as a way to change things in our country. And I think it was just sort of natural for me as I started my training in the ER, where I was seeing folks who are marginalized by our healthcare system. Millions and millions of people who come to the ER every single day for no medical emergency, where the only emergency that they have is that they don't have a primary care doctor in the richest country in the world, or the only emergency that they have is that they are uninsured or underinsured. And so I began thinking about, well, gee, I mean, if we're going to solve problems like this, we've got to be at a higher level in terms of organizing and mobilizing both patients and doctors. And so I learned that actually healthcare-based voter registration is, number one, legal. The 1993 Motor Voter Law, the 1993 National Voter Registration Act, made it possible and encouraged nonprofits and other institutions that give federal resources to do voter registration in a nonpartisan way. So I did not know previous to that hospitals could do that work. And once I found that out, it was sort of a little bit of off to the races to try and create a basic, minimally viable product, which initially was a kiosk that we were putting in ERs and community health center waiting rooms. And over time, it has developed into a smaller and smaller and smaller, and now a sort of handheld approach with these healthy democracy kits that allow patients to register themselves. There aren't any doctors or nurses walking around with clipboards in the ER or in primary care clinics. This is just a way for people to be reminded that you should register to vote and to register to vote on their own phones.
Thank you. This actually leads nicely into a question I have for Dr. McKenna, sort of around how can sort of so you spend a lot of time studying how collective action can be translated into success. And what lessons could you maybe apply to your research to help, voter registration, civic engagement in a healthcare setting, particularly in the midst of a pandemic?
Great question. So first of all, what did COVID do to political organizing in the US? I think that's a critical question. And in March and April, when everything had to go online immediately, a lot of the kinds of grassroots organization that I and Professor Hahn study, who do a great deal of relational, in-person, face-to-face organizing, were forced to go online. And so what happened in March and April was the narrative was simply, well, relational organizing, face-to-face organizing is dead because no one can see each other in person anymore. And so there was a chorus of primarily political consultants who were talking about now all politics, the most effective way to mobilize people is going to be through digital ads. And that's not what happened at all. What actually we've seen over the past few months is that the organizing work that formerly happened face-to-face in relational spaces in places like church basements or in community centers ended up moving online. And the reason that many of the most successful groups that we've seen who've been able to actually not just mobilize large numbers of people, but also organize them in collective vehicles that have the long-term potential to shift power, have a say over the policy decisions that affect them, ended up being very adaptable. And the reason they were able to do that was because they had a really committed base of relationally connected people. So I think what's most important to point out, and what we found in our research over and over and over again, is that simply aggregating votes, dollars, resources of any kind does not necessarily translate into political power, certainly not durable political power, but rather kind of creating these organizational vehicles that are full of leaders and strategists who are able to kind of identify the political moment and be able to respond to something as unpredictable and devastating as something like COVID-19. So I had one slide to share just on this question about efficacy of political organizations. And I'm going to see if you can see. Can you see my slide now?
Yes, we can. Okay,
great. So let's see. Here we go. So what I wanted to show you was actually this research. I'm going to switch forward a little bit. From Baumgartner et al. In 2009. And what they looked at was what type of resource translates into political power. And so what this table shows is the first column, the type of resource, high-level government allies, mid-level government allies, lobbying expenditures, membership, et cetera. And the second column is the percent of issues where the side with greater control of that resource won. And what's remarkable about this table is in the bottom, you see membership, which is to say the membership size, the number of people involved, or we could even think about number of voters, only 50% of the time won on the issue. And so the takeaway from this table is that it's less important simply how many numbers you have or how many people you have that show up at a protest, but rather how they are strategically connected to both each other and these high-level government officials. So that's sort of one major prompt for the research that we do at the P3 Lab. I think we're going to drop a link in the chat for the book that we have that looks in depth at 6 different grassroots organizations that were able to, even though they had fewer resources, mobilize and organize a constituency such that they moved and shifted political power in a durable way. So I'm going to stop my share now.
Thank you. So this gives me a couple of thoughts. One, I think you're sort of alluding to the need to not just have people registered to vote, but also really making sure they're linking in structures of power and really understanding and motivated to vote and understand issues that affect their health. I think where I want to move this is, I'd like to hear from you, Dr. Ballard, about sort of how voting and civic engagement is linked to healthcare outcomes. And I'd like to hear from Dr. Turner and Dr. Martin about how you communicate with your patients about linking their health with voting.
Sure. So I can talk a little bit about research linking voting with health outcomes. I'm a developmental psychologist and my research is more at the individual level. So I can just kind of quickly touch on that and then turn it over to Drs. Martin and Turner about healthcare outcomes. So we have emergent evidence that voting is associated with positive health outcomes for individuals. So since I have the floor, if you'll indulge me, I'm just going to talk about one study very briefly, and I think we'll also drop a link to the paper if people want to read more. But I, along with a couple of colleagues, did a large study looking at just under 10,000 young people and looking in a pretty rigorous way at voting when young people were around age 18 and following them through young adulthood and looking at how that related with health outcomes and socioeconomic outcomes. And we found that voting was related with better mental health outcomes and better health behavior outcomes measured by fewer risky health behaviors 10 years later into young adulthood. We also found that voting was related with socioeconomic outcomes like educational attainment and higher income. This particular study was pretty cool because it used a big data set called Ad Health, which is a large study and a representative study, and allowed us to look at these questions in a pretty rigorous way. And there's other research out there finding similarly that voting is related with individual positive health outcomes. Again, this research is pretty emergent, but it's promising. We weren't able to really look at why, but we have some ideas. I like to think about voting as one indicator of a broader pattern of civic engagement. And when people are civically engaged, we find that they often feel connected to their community, feel empowered, like they have a voice in community and society, and also have a sense that they have opportunities to contribute to a greater good. And I think all of those things can be associated with better mood, just feeling positive kind of well-being. And those things can potentially impact individual level health in positive ways. So that's what the research is finding.
Dr. Turner, I'd also be curious to hear your thoughts on, both in your role as a practicing physician on how to communicate to patients about voting, and then how that's also sort of informed in your desire to increase voter participation linking it to health.
Well, first of all, listening to the last couple of comments, a couple of things really popped out that I thought that were great. We need to emphasize. One, the idea that voting can be connected to other civic engagement also, but it gives you a voice. And I really think that empowers people just to know that, yes, I was part of that process. What I found, in the past in many issues, is that the one-on-one approach is really valuable. Obviously, we can't do it as well now, but when I've been talking with patients or with even staff that I engage with, because even all medical staff don't necessarily at all levels engage in voting, okay? But if somebody asks you personally to do something, you're more likely to respond than if you get the ask from an anonymous person in a large group, for example. So a lot of times in the process of just talking with patients, and just like Dr. Martin's talked about his interaction with patients, is that one-on-one, simply just asking them, have you registered, or do you want to register, or do you want to vote? Or if they bring up an issue, just making the connection between, if that's a concern of yours, it may be valuable for you to voice that by voting. And we can do that in larger groups too, but I really think that thinking of ways that we can make that one-on-one ask, whether it's in a one-on-one interaction with a patient, or if it's in a group interaction with a patient, or if it's on a actual interaction with a patient. For example, when you're doing telehealth or something like that, there are ways to connect with people. And I really like the comment that was made about the organizing, because one of the things that the League recognized as it moves into its second, 100 years, is that we were missing that kind of activist organizing piece, and we now have a really growing organizing department of our of the League, and we're finding that is bringing people together too. And so I appreciate that comment about how organizing really makes a difference also. So
thank you. And Dr. Martin, I'd like to hear from you on this. Thank you.
Yeah, great. So the first thing I'll say is that we are at VOTI are really trying to explore this space of how do you talk about electoral participation in the exam room in a way that's non-coercive, in a way that's non-partisan, in a way that's non-interruptive. And the good news that we have is the data from the field so far suggests that we're helping our physicians do that across the country. We've gotten thousands of folks either registered to vote already or gotten their mail-in ballots, which has been really inspiring to see. But look, the way I typically do it is with patients, I say, look, with all that's going on with COVID-19, I want to make sure that you can vote in a safe and healthy way in the upcoming election if you're able to. Are you ready to vote in the next election? And it's as simple as that. And so that conversation typically leads to, oh yeah, I'm registered to vote. And often I can say, okay, awesome. Well, if you're interested, while you're here, you can take a look at how to get your mail-in ballot. Or if folks say, no, I'm not registered. I might say, okay, fantastic. Well, no worries. Our hospital can now help you get registered to vote. If you want to, just let me know and you can start the process. Send this text message or shoot this QR code. And so that is some of the work we're doing to sort of develop some of that scripting to make it easy and natural. Look, physicians ask patients all kinds of awkward questions. And so, there shouldn't be stigma around getting people to participate in what is the most important civic duty that we have in our country.
Thank you. So I think for a next question, sort of zooming out, I want to start with you, Dr. McKenna here. is there sort of a precedent in the past for healthcare and civic engagement to work together, and can we learn from any past efforts, or in regards to sort of organizing around healthcare and civic engagement?
So as I said at the top, I think there are lessons about organizing that are general, irrespective of the field. So health, climate, education. And what we found in our research, I received a provocation from Marshall Gans offline in the chat when I showed that table about how, look, membership doesn't matter. The number of people you have involved doesn't matter. And I really want to clarify that in response to your question and in response to Marshall Gans, which is that, in fact, of course, membership matters. What we found is that the quality, it's not simply the number of people that you have on your side that is going to determine whether or not you effectively achieve your goals, but rather how those constituents are organized and connected to one another as a resource. So the takeaway from that chart wasn't simply go find yourself a DC lobbyist, but rather how do you organize a constituency base that is going to remain committed to each other and to the organization throughout multiple electoral cycles. So if I can just share one more slide on that topic. Can you see my screen? Can you see my screen? Yes? Yes, okay. So what we have here are two networks of decision makers in one of our case studies. So the different nodes represent different types of decision makers, and the arrow is pointing to a civic leader who in 2013 did not have an organized constituency base, and in 2016 became sort of the central broker inside of that network as a result of the, this was related not to a healthcare issue, but rather a universal preschool measure in Cincinnati. This is one of the cases in our books. But what it shows you is that by leveraging this organized base, he was able to shift the policy outcome that they cared about. So that's one example of how that worked. We also looked at voting rights for returning citizens in Virginia. We looked at shifting gubernatorial narratives in Minnesota and the response to the SB 1070 immigration bill in Arizona passed in 2010.
Great, thank you. So it sounds like there's an opportunity here for physicians particularly to become sort of more connected nodes to help drive change and also link people to constituencies there. And then I think shifting gears to Dr. Ballard, I'd be curious to hear your comments regarding, dynamics around health equity, and sort of how can we sort of find a better way to both communicate to patients about civic engagement, or also talk about emerging research regarding healthcare and civic engagement beyond the study you cited, or things that are perhaps ongoing.
Yeah, a couple thoughts. I mean, one, in terms of effectively engaging with patients, I think start early and do it often. I'm not a physician, so it's easy to say, right? Easy for me as a researcher to say, hey, you should be doing this. Of course, physicians and healthcare providers have a million things they should be talking to patients about. But I am a developmental psychologist, so I have to say that thinking in a civic way starts early. So it's not only you turn 18, you can vote, get registered, it's start conversations early. And that's for everybody. So, to Dr. Turner's point, one-on-one conversations matter a lot for inspiring people. And so does the idea of starting where people are, right? People have things they're passionate about, and different people have different areas of passion. So starting with people when they're young, like, what do you care about in your community? Do you have opportunities? Just asking the questions, whether it be from a healthcare provider or a teacher, or in your role as just a human that interacts with other people, can be a really powerful way to start the conversation and plant a seed that can grow over time, so that people start getting in a civic mindset, start noticing issues that matter and opportunities to get involved. And then by the time they're of age to vote, that is a natural part of a progression of thinking in a civic way about issues.
Great, thank you so much. I also actually want to ask a follow-up question of you, which is more regarding sort of past efforts to sort of study this relation between civic engagement and health, and maybe you can educate us on there and perhaps give us some, is this a recently emerging area of study, or is this sort of something that has been known for a long time?
So let me answer that in a couple ways. It's not a new area of study, but I would say I would characterize the first kind of era of research on the topic of civic engagement and health as observational or correlational. So we have some evidence that civic engagement is linked with better health or associated with better health. What we don't know so much is why, and if voting or more broadly civic engagement causes good health, right? That's the issue of causality is a whole separate question. So I think what research is doing more recently is moving into that question of, well, are there interventions that we can, put in place and study whether intervening in, let's say, in schools or in healthcare settings can cause people to vote more, and does that cause better health outcomes? That is really tricky to study. So that's one of the reasons why I think that the more recent era of research is kind of turning to those questions of causality and really thinking about methods to really understand the causal implications of civic engagement on health and well-being.
Great, thank you. I think we're going to start off with some audience questions now as well. So one question we received is about, asking you all, can you address the recent shortened time to complete the census and how census participation impacts health services and outcomes as well as civic engagement, at least in regards to your fields? Perhaps let's start with you, Dr. Turner, if you're willing to start off here.
Sure, absolutely. As we know, and sometimes I wonder if it's really important to understand that counting the people living in the United States is going to make a difference in not only how you are redistricted and how many votes you get in Congress and whatever, but also in the money that's going to come to your area. So if you need money for healthcare, if you need money for schools, almost every dollar that comes through the federal process is going to be related to the census and how many people are living in your area. So if you're not counted or you are blocked from being counted, that means that the funding is going to be spread out disproportionately, and areas particularly that have been in the past disenfranchised, areas that have, many of our minority groups in the country have lower economic advantage or opportunities are going to be the areas that will not be counted and therefore will lose more federal funding and therefore in the end will suffer more. And I was really distressed, I'll just put this out there, to hear that this discussion around stopping the vote, the counting of the census a month early, this is critical and something that we really need to jump on. So I'm just throw that out there.
Thank you. I've had from the audience is for you, Dr. Martin, which is, VoteR has this really awesome QR code. How do you sort of link civic engagement without a smartphone? Is this where the kiosks would come in?
Yeah, great question. So I'll tell you the story of some of our homeless shelters that we work with. So patients who are part of these shelters aren't always able to access the QR codes or the text messaging platforms. And so in that case, we have actually an iPad kiosk, as you mentioned, Lucas, that people can walk up to and use in that way. We don't use the paper-based form in the vast majority of cases. There are a few exceptions. We've got, I would say, out of the 100 hospitals, maybe one or two that do the paper-based form, but it is sort of more fraught with potential for human error, and hospitals have other priorities, and sometimes paper forms get lost, and so we don't really want to do much with sort of the paper-based approach. So, and that's mostly to protect both the patient and also the hospital.
Great, thank you. Another question we had from the audience is it possible to remove policing from the medical industrial complex? How do we make the language of the medical field accessible to people so that they actually understand the short-term and long-term consequences of our civic engagement? Would Dr. McKenna or Dr. Ballard be interested in responding to this question? And then perhaps we can hear from either Dr. Turner or Dr. Martin from a physician's perspective, or from Dr. Turner from your position as head of League of Women Voters.
I'd be happy to take a quick response to that. And I think it's a great question. And what it gets at is sort of what the political theorist Stephen Lukes calls the three faces of power. So this is the quick slide that I went past. It looks like, if you think about it like an iceberg. So Stephen Lukes talks about these three faces. The first face would be sort of the tip of the iceberg. Who wins and who loses? What happened? Who do the police arrest? who is it that is having starvation ketosis? Those are sort of the immediate visible manifestations of what happens underneath the waterline. So the second face of power looks at what continues to happen over and over again. And then the third face of power, the least visible, the most difficult to see, asks what causes these patterns to be maintained. So I think, at the risk of sounding a little bit like a broken record, this is what organizers get at, is the root causes, what issues are even up for debate. Moments of rupture can bring to the fore, like what has happened in the United States since the George Floyd killing and the uprisings that resulted. That's sort of the tip of the iceberg. That's what's immediately visible. But in order to address sort of the systemic and infrastructural issues, we have to look at what continues to happen and what causes those patterns to be maintained. And that's sort of the intuition behind building constituency-based organizations that address not just one single issue and one single election and what happens at the tip of the iceberg, but rather those other two faces of power as well.
And can I just add here, I really liked Dr. McKenna's point about root causes, and it's something really important to me, again, as a psychologist, often looking at the individual level, that we make sure to remember that civic engagement is not only individual, and it's important to not ask people to fix systems that they're a part of. So I think I heard a question as part of the question that was just asked about accessibility and accessible language. And I think I would partly answer that by saying, again, start where people are and what they're interested in, and connect with their own interests and help them see the connections between their own interests and root causes and systems. And that's a complicated thing to do. I'm not sure how to answer how healthcare providers can do that, but it's a larger conversation that I think individuals, we want them to be empowered and feel their voice matters, but also understand that there are, of course, larger systems at work and there are root causes, and it's complicated. But making language accessible, I think, starts with where people are, understanding where they are, and understanding their place within systems.
Thinking about what both you just said, which is, and it goes back to Dr. Martin's story he told about his patient too, and about mine, is that issue of, we have a tendency just to look at the tip of the iceberg, so true. And when we are faced with or dealing with a patient who has a given entity, whatever it may be, illness, problem, injury, whatever, many times the things that led to that illness or led to that disease have nothing to do with the immediate issue. Okay. So many times there are things that are happening on the home front or in their community or otherwise that have gotten them to the point where they show up with this given entity, but we haven't looked below. So one of the things that I think healthcare providers need to do better and need to understand probably better is that many times we are in such a rush and there's so much going on that we're at the tip of the iceberg. Dr. Martin's laughing. And we forget that there are underlying causes that if we can help with those, or at least guide or direct people to ways that they can deal with the underlying causes, that eventually we will stop seeing those things happening in the tip of the iceberg. Does that make sense, Dr. Martin? You know what I'm trying to say here?
I couldn't agree with that more. I had a patient, this is now, 5 or 6 months ago, who just knocked me off my feet. I remember, and because it happened to me, I was being biased. She had diabetes. She was in her early 30s, Latinx woman. And, it's embarrassing for me to even tell this story, but she came in with a very rare complication of diabetes called DKA. It's very rare, deadly. And I remember sitting at the computer station with a team of other doctors and residents. We were reviewing her chart, and we realized, I think it might have been a Wednesday or Thursday, we realized she had the same exact thing just 5 days prior to that. This woman had DKA twice in 1 week. Some people with diabetes never, ever, ever, ever have DKA. And so, what medical school teaches us is that patients are non-compliant, that there's some intrinsic moral failure that they have that makes them forgetful, or they don't want to take their medication. And I remember we were having this conversation about, why moving fast, as Dr. Turner mentioned, moving fast. We were thinking, why can't she just take her insulin? What's going on? You know, how do you have DK twice in 1 week? And then I remember taking a moment and saying, well, hold on, maybe I'm missing something. Let me go talk to her and figure out more about, you know, let me get the real story, right? And it turns out that she had lost her insurance and she was rationing her insulin over 6 weeks, taking smaller and smaller and smaller and smaller doses of her insulin. And when she told me that, I just didn't know what to say, right? We had painted this woman as being sort of non-compliant, unable to take care of herself. In reality, it was not her failure, it was the state failure. It was the failure of health policy, the failure of us to come up with a rational healthcare system that can protect folks like her, which is what we ought to be doing in the first place. So I could not agree with that sentiment more, Dr. Turner.
Thank you. And I think sort of building off of that question, also alluding to a comment Dr. Turner made earlier around sort of efforts to suppress the vote. I'd be curious to hear each of your thoughts on both current situations where the vote is suppressed, and either a personal anecdote or more academic study that may touch on how sort of voter suppression may actually impact one's health. I think if perhaps we hear from you, Dr. Turner, I think given the comment earlier. And also I think perhaps maybe you could touch on some work about the League of Women Voters and perhaps some of the burgeoning activism there you mentioned as well.
Right. Well, clearly, if the voices of those who are marginalized, and I like to say disenfranchised, because that's what we really have done is disenfranchised folks, are not heard, then their issues are not taken care of at the ballot box. They may not even get on the ballot for that matter. And therefore, their health eventually suffers, because if you're making a decision about healthcare in your community, for example, and you're going to be voting, say, for a new health center to be placed in a given part of your town, and the people who are voting for it are the people who don't even live in that part of town, have no actual purchase in that issue. And the voices of the people who are there are not heard, because either they don't have the polling sites or they can't vote on voters on election day because they can't get off time and work, or they haven't had access to a mail-in ballot because it has not been a process that has been promoted for them or they've given the opportunity. So therefore, their issue does not get voted on. Therefore, they lose their access maybe to that new clinic, for example, and therefore their health suffers because they were unable to, have their voice heard. So the whole issue of having universal voting really impacts the healthcare area in so many ways, not just in whether you can get your medication, which is key, the cost of pharmaceuticals, which is key, but where the clinics are. Where do we have systems that are built such that if you need care that you can achieve that care? Or why can't you get it in your community? Because your community doesn't have the funding to have those there. Most people would love to have their health care given to them or provided in their community, but they may not have access because they don't have the right doctors or the right clinics in that. And how are the decisions made? They're made through voting and through elected officials. I just, it's all part of a big conglomerate that we have to parse out and then put back together in the right way. So
I think this actually links nicely with your work, Dr. McKenna, around sort of networks and sort of increasing the power behind those decision makers. Can I perhaps get a comment from you on this?
Sure. I apologize for the infant crying in the background. To that question, and also this line of questions about data and the census and voter suppression, one thing that we found in a lot of the groups that we work with is even progressive, small d democracy enhancing organizations end up being complicit in some kinds of voter suppression efforts in the following ways. They rely on platforms that invisibilize certain voters or potential voters. So there's something called the voter file, or the VAN, that most campaigns use. And what it uses is data to identify a vote propensity score for every individual in the United States. And those vote propensity scores feed into the campaign work. And so what ends up happening is these campaigns, which have limited resources, rank order potential voters by their vote propensity. Well, it shouldn't surprise anyone that those with the highest vote propensity scores end up being generally white people, those people who have addresses that haven't moved in the past several years. And so what ends up happening is that even progressive campaigns and organizations that hope to enfranchise or engage a wider multiracial base of people end up doing just the opposite. And that's a function of, I've seen this come up in the questions over and over again, the data being power and that sort of thing. And that's why also the census is important as well. So that was just sort of a comment I wanted to share with respect to ways in which sometimes organizations that are trying to be as democratic as possible end up being complicit in some of those disenfranchisement traps.
I just want to build on that excellent point very quickly. Look, the bottom line is politicians, political institutions formulate policy and platforms on the basis of who is registered and who votes. And, for folks who are paying attention, we have 50 million people who are not registered in this country. That's a quarter of the population of voting age eligible individuals. And then you look at folks who think that they're registered, but actually are not registered because they moved or they got married and their name changed. Another 30 million people. So you have 80 million people who are potentially carved out from the national we. And you can't have a system, or maybe you can. You end up with the inequality we have in our healthcare system, the economic inequality, the brutal criminal justice system that we have. We have to start by getting people registered to vote. We have to start by expanding the electorate yesterday. Depends on it. The nation and the health of our democracy depends on it.
Great, thank you. And actually, I want to ask you, Dr. Martin, particularly a question from the audience for opening it up, because you alluded to sort of your medical education, how it sort of impacted your role in understanding civic engagement, the broader determinants of health. So one question from the audience is, are any of the panelists aware of efforts related to civic engagement within the medical education community? For example, medical students, residents, allied health, et cetera. The examples presented are more in the intervention setting, and if you're aware of any efforts within sort of education setting to perhaps address civic engagement in the medical community or go beyond there.
Yeah, Katrina, this is just such a great question. One of the things that I've been most inspired by has been the response to from the medical community post George Floyd. If you were to look at our orders for these healthy democracy kits, before May 25th is the day that George Floyd was murdered. Before that time, we had tepid growth and it was plateaued. After that date and after the protest started, we saw this exponential increase that sustained. We now have, somewhere between 15 to 20,000 of these orders that we have to get out in the next couple of weeks. And that's fantastic. A lot of that was driven by medical students, young people. The second inspiring thing that I want to tell you is that we just figured out how to gamify. I know this is going to sound weird, but how to gamify the whole voter registration and mail-in ballot process. Meaning, every time someone, a medical student or a provider, gets someone registered to vote, we have figured out how to track that and to convert that into a point on a scoreboard. So, if you're thinking what I'm thinking, we've created a competition between medical schools. And one of the most inspiring things that we have seen is we did a preseason, effectively a pilot, where we had two medical schools competing against each other, Duke Medical School versus UNC Medical School. And these students came up with such innovative ways to get people registered to vote, going to COVID drive-through screening clinics with their white coats on and a big sign that says, honk if you want to get registered to vote. They would then airdrop on their iPhone voter registration links to people in their cars. Never heard of something like that before. Things like starting Twitter storms. I still don't know what a Twitter storm is, but they did it. Over the course of just 10 days, they got 550 people registered to vote or their mail-in ballots. And so we've just launched a broader 50 school competition because of that. And we hope to see 50x the result of that. So.
And if I may interject here for a second, for the Harvard attendees on this call, we are currently losing to you, so please step it up. Any other comments on sort of medical education or interventions from civic engagement on the medical education side?
Go ahead.
I just wanted to add quickly, it seems to me that medical med ed kinds of efforts tend to be local. So I don't know that I know of a national effort like that. I do know of one project out of the Bay Area called the Voice Project. So I can drop a link to it in the chat box that may be helpful for Katrina to check out.
Thank you. And Dr. Turner.
Yeah, I was going to say that's very exciting, and I would love to make sure our medical schools in the area where I'm living right now are engaged in that, Dr. Martin. And I think to that point that almost every medical school has a medical students association of some kind for another. Sometimes they're actually around just the basic American Medical Association, but sometimes they're around specific issues. So there are medical schools and there are medical student groups that are out there fighting for multiple things on multiple different levels. And if we can engage them too, and not only believing in and working for the point they're interested in, but also turning that into registered voters, that would be exceptional. And I just like to throw out that I haven't got mine, I'm waiting for mine, Dr. Martin, my packet, but I'm sure it's on its way. But also just reminding folks that the League of Women Voters has a really simple app called Vote 411. And it's a platform that not only has everything on it for every state in the country. It tells you where you vote. It can tell you what your precinct is. It can tell you, and also has information on who's running in your district or running in your area, what topics are, what they believe in. So you have a wealth of information just by going to Vote 411 too. So it's another avenue that you can use. And I'm encouraging people to have Zoom parties and to invite their friends to join them, have a little Vote 411 Zoom party, and everybody signs up. So.
Thank you. And I think for one last question, I think sort of translating back to this sort of more academic discussion into translating into action, I'd be curious to hear sort of, particularly from you, Dr. Martin and Dr. Turner, about how your efforts to get hospital admin involved in this and the importance of getting their support, or were you able to accomplish this sort of from a grassroots level?
So great question. I'll try to answer briefly. We used a grass tops and a grassroots approach. So grassroots via social media, via getting out the word from folks who have these kits already, telling their friends. We use a relational organizing approach. So when people get one of these kits, their first action is to identify, this is the box it actually comes in, is to identify who are two other people that might want to use the kit. So from the grassroots process, we have gotten some spread. And then from the grass tops process, we've gotten the American Academy of Pediatrics, the National Association of Community Health Centers, and a bunch of other organizations, 50 organizations that are healthcare advocacy organizations and others, to help us get this message out from the grass tops down. So for Civic Health Month.
Thank you.
And just from my point of view, I currently don't work directly with a hospital, but within our organization, we have our advocacy departments, and which are, we have both regular advocacy staff who obviously work on these issues, but we have a lot of young volunteers from all walks of life that are basically working on getting out the vote, and not just registering, but our really big push right now is that we can register millions of people, but if they don't vote, then it's not very beneficial. So our really push at this point is getting out the vote and touching those folks and making sure that they're, voting so that the vote can count.
Thank you. Any last comments? Okay, if not, I'd like to thank sorry. Okay. If not, I'd like to thank everyone for an informative conversation. And again, this talk will be posted to the Ash Center website for later viewing. And I'd like to thank the audience for joining us all today. Thank you so much, and have a good rest of your afternoons.